All right, so today we're taking a deep dive into, well, it's a bit of a medical mystery, Guillain-Barré Syndrome. You might know it as GBS.
Yeah, GBS definitely a bit of a head scratcher, even for us in the medical field.
You sent over some fascinating research on it, specifically an article from a medical journal, and honestly, there's a lot to unpack. But before we get into the nitty-gritty, something in the article really surprised me, and I gotta ask, did you know men are actually more likely to develop GBS?
It is interesting, isn't it? And while it's considered a rare condition, the chances do go up, if you've ever had a run-in with a specific type of bacteria. Campylobacter jejuni, often found in, well, you've probably heard it before, undercooked poultry.
Oh, so like that barbecue chicken that wasn't quite done?
Yeah, exactly. Now, as for why men might be more susceptible, well, the jury's still out on that one. Could be all sorts of factors, right? Differences in diet, occupational hazards, or maybe, just maybe, men are just a tad less likely to pass up that last undercooked wing.
Maybe. But on a more serious note, that whole connection is pretty wild. And it seems like with GBS, there's always more to uncover. So, for our listeners who are hearing about Guillain-Barré syndrome for the first time, what's the quick explanation?
Imagine this. Your body's defense system, your immune system, it's like it suddenly mistakes your own nerves for invaders. And bam, that's Guillain-Barré syndrome in essence. It's an autoimmune disease, meaning the immune system gets a little confused and starts attacking the peripheral nervous system. Basically, the network of nerves outside your brain and spinal cord.
And those nerves, they're kind of a big deal, right? I mean, they're responsible for a lot.
Oh, absolutely. They're the messengers, if you will, carrying signals that allow you to move your muscles, feel sensations, even control vital things like breathing. So you can imagine when those nerves are under attack, it can have some, well, pretty serious consequences.
Yeah, that makes a lot of sense. Now, this article you shared, it mentioned GBS often unfolds in phases. Can you walk us through those?
Sure. It often starts with what we call the prodrome phase. It's almost like, a little warning tremor before an earthquake. Think of it this way. Many people with GBS, they report having had some kind of infection in the weeks leading up to their symptoms.
So something like, I don't know, a nasty flu, or thinking back to our earlier chat, even a bout of food poisoning from, say, some undercooked chicken.
Exactly. Those are what we call antecedent infections. They happen before GBS really takes hold. We see links to Campylobacter jejuni, as we mentioned, but also cytomegalovirus, even the Epstein-Barr virus. It's almost like the immune system is, well, it's like it gets a little confused after fighting off one invader and then accidentally sets its sights on the nervous system.
Wow, talk about a case of mistaken identity. So after this prodrome phase, what's next in the lineup?
Things tend to escalate pretty quickly to the progressive phase. This is where those telltale GBS symptoms, the muscle weakness, the tingling, sometimes even paralysis, they really start to take center stage.
And how quickly are we talking here? Like, is this a matter of days, weeks?
It can vary a bit from person to person, but typically within about 2 weeks of those initial symptoms popping up, things kind of reach their peak. And this is a really critical window because ideally, the faster we can diagnose GBS, the better the chances of a good recovery.
So early detection is really key here.
Exactly.
It makes sense that doctors would want to catch it during this progressive phase when it's, well, progressing. But after that peak, what comes next? Does it just sort of plateau?
You hit the nail on the head. The next act in this whole sequence is the plateau phase. It's a period of, relative stability. Symptoms aren't necessarily getting worse, but they're not exactly throwing a party either. They're just kind of hanging out. At this phase, it can last a few days, maybe even a couple of weeks. It's almost like your body's taking a well-deserved breather before embarking on that long road to recovery.
I see. So it's a bit of a waiting game for both the patient and the medical team.
You could say that.
But then finally, there's a glimmer of hope, right? We reach the recovery phase. Tell us more about that.
This is where things start looking up. The body finally begins that, unfortunately, often lengthy process of repairing all that damage to the nerves. And nerves, they do regenerate, but they take their sweet time at a pace of, believe it or not, about an inch per month.
Wow.
Yeah.
So we're talking potentially months, maybe even a year or more for a full recovery. That's quite a journey.
Yeah,
It seems like patience is a real virtue when it comes to GBS.
absolutely. Patience is key.
Now, the article you shared, it dove into different types of GBS. Do you mind if we spend a little time exploring those variations?
Yeah, of course, because Guillain-Barré syndrome, it's not, a one-size-fits-all kind of diagnosis.
Right.
There are several subtypes, each with its own quirks. The most common here in the U.S., it's a bit of a mouthful, it's called ADP, or acute inflammatory demyelinating polyradiculoneuropathy.
Okay, I'll be honest, I might need a bit of a translation for that one.
Fair enough. Let's simplify things.
Yeah.
Imagine your nerves are like electrical wires, right?
Okay.
And they're coated in this protective layer, this insulation called myelin.
Gotcha.
In ADP, the immune system, well-meaning as it is, decides to attack this myelin, causing those electrical signals to, you guessed it, short circuit.
Ah, okay, so that's what's messing with the nerve signals and causing those issues with weakness, numbness, and all that.
You got it. But, believe it or not, that's not the only way GBS can wreak havoc on the nervous system. We also have what are called axonal variants, things like AMAN and AMSN. Now, these are more commonly seen over in Asia and often crop up after, a bout of, well, let's just say an unpleasant diarrheal illness.
Interesting. So how do those differ from the ADP we were just talking about?
Well, instead of going after the myelin, these subtypes, they set their sights on the axon itself. Think of it as the actual wire carrying the electrical signal, not just the insulation.
So it's like in one case you're damaging the insulation and in the other you're cutting the wire itself.
A perfect analogy. Different types of GBS, different ways of interfering with those all-important nerve signals.
Gotcha. Are there any other variations on this GBS theme that we should be familiar with?
There's one more that's, well, it's almost like a medical trivia question, Miller-Fisher syndrome.
Okay.
It's not as common, but what's really fascinating about this one is that it shows up with this very distinct trio of symptoms. They are ophthalmoplegia, ataxia, and arflexia.
All right, you're going to have to break those down for me.
You're right. Big words. Ophthalmoplegia basically means paralysis of the eye muscles.
Okay.
Ataxia that throws off your balance and coordination.
Okay.
And arflexia, that's a lack of reflexes. So imagine trying to, I don't know, hit a moving target, but your eyes won't cooperate, your balance is all over the place, and you can't react quickly enough. That gives you a little taste of what it's like to experience this particular form of GBS.
Wow, it sounds like something out of a medical thriller, that's for sure. I think it's time we dive a little deeper into the science behind all of this. Let's talk about this whole idea of molecular mimicry, where the immune system gets tricked, fooled into attacking the body's own nerves. How does that actually play out at the microscopic level?
I am happy to delve into that. It is where things get really interesting. You ready to talk about gangliosides?
Gangliosides. Okay, I'm not gonna lie, it sounds a little bit like we're about to enter a science fiction movie here.
A little bit, right. But bear with me. It's actually pretty fascinating.
Okay, well, I'm all ears. Lay it on me. What are these gangliosides and what's their role in all of this?
Okay, so picture this. You've got those infections that we were talking about earlier, the ones that often seem to set the stage for GBS, right? Now, these infections, they have these tiny little molecules on their surfaces. Think of them like, I don't know, little identifying markers, almost like name tags.
Okay.
And here's the thing, sometimes, just sometimes, those markers, they bear a striking resemblance to molecules that are naturally found on the surface of your nerve cells. And guess what those molecules are called? You got gangliosides.
Ah, okay, I'm starting to see where this is going. So it's like these infections are, wearing a disguise, making themselves look like they belong in the nervous system.
Precisely. Like wolves in sheep's clothing, these infections sneak in. And your immune system, always the vigilant guard, it sees these imposters and thinks, hold on a minute, something's not right here. And that's when it launches a full-on attack, creating these, well, they're like little soldiers antibodies, specifically designed to target those molecules.
But then those antibodies, they can't really tell the difference between the real deal and the imposters, right?
That's the problem, unfortunately. Those antibodies, they're primed and ready for battle, but they end up targeting not just the infection, but also your own nerve cells, mistaking them for the enemy. A classic case of friendly fire, but on a microscopic level,
Oh man, that's rough. So these gangliosides, they're like the innocent bystanders caught in the crossfire.
Exactly. And here's where it gets even more interesting. Different types of gangliosides are associated with different subtypes of GBS. So for instance, with MNN, that axonal variant we were discussing earlier, we often see antibodies going after these specific gangliosides, GM1 and GD1A.
So it's like by identifying which gangliosides are being targeted, doctors can get a better handle on which particular flavor of GBS someone has.
Exactly. It's all about connecting the dots, putting those puzzle pieces together. These ganglioside antibodies, they're like clues, helping us understand the specific subtype of GBS we're dealing with, which is really important because it helps guide treatment.
That makes a lot of sense. But this all begs the question, how do doctors actually go about diagnosing GBS? I mean, if it can be triggered by so many things and then show up with such a wide range of symptoms, it's almost like trying to find I don't know, a specific grain of sand on the beach?
Oh, it can definitely be tricky, especially early on. Those initial symptoms, they can mimic other neurological conditions. It's like trying to solve a medical mystery, really. But there are a few key tools that doctors use. One of the big ones is a lumbar puncture. You might have heard it called a spinal tap.
Yeah, not exactly the most, shall we say, appealing sounding procedure, but I get why it's necessary.
Right. We need a way to get a glimpse of what's going on inside the nervous system. And often what we find in the cerebrospinal fluid of someone with GBS is something called albuminocytologic dissociation.
Okay, gotta admit, that one's a mouthful. Can you break it down for me?
Of course, in simple terms, it means we're seeing a high level of protein in that cerebrospinal fluid. But the white blood cell count, it stays pretty normal.
Okay, and why is that significant?
It's a bit of a red flag. It tells us there's inflammation happening in the nervous system, which points us in the direction of GBS. But of course, the lumbar puncture alone isn't enough to make a definitive diagnosis. Doctors also rely on nerve conduction studies and electromyography, EMG for short.
Ah, yes, EMG. I've heard of those. Can you give us a quick refresher on what those tests actually involve?
Absolutely. Nerve conduction studies, as the name implies, measure how quickly those electrical impulses are traveling along the nerves. And in GBS, remember all that damage to the myelin or the axon that we were talking about?
Right.
Well, because of that damage, those signals, they often get slowed down. Sometimes they're even weakened.
So it's almost like you're measuring the flow of traffic on those nerve highways, and in GBS, there's like a major slowdown, maybe even a roadblock somewhere.
Exactly. A great way to put it. And then there's EMG, which looks at the electrical activity of the muscles themselves. This helps us figure out how well those nerve signals are actually reaching their intended target, those muscles, and if there's any damage to the muscles themselves.
So by putting all of these pieces together, the symptoms, the spinal fluid analysis, the nerve and muscle tests, doctors can get a much clearer picture of what's happening in the nervous system and confidently say, okay, this looks like GBS.
Precisely. It's like piecing together a complex puzzle. And here's something else that's pretty amazing. We're actually on the verge of having even more advanced diagnostic tools. Imagine being able to actually visualize nerve swelling with something like an ultrasound, or even just doing a simple blood test to detect specific biomarkers that tell us, yep, this is GBS.
Wow, that would be incredible. Talk about a game changer.
It would revolutionize how we approach GBS.
Absolutely. But for now, let's bring it back to the present. For someone who has been diagnosed with GBS, what are the treatment options? What can be done to, calm down that immune system frenzy and get those nerves back on track? So we've talked about how GBS is diagnosed, but what about treatment? What can be done to, hit the brakes on this whole immune system frenzy and get those nerves back to doing what they do best?
Well, the good news is we do have effective treatments for GBS. And generally speaking, the earlier we can start those treatments, the better the outcome tends to be. We typically approach it from two angles. Supportive care and then immunotherapy.
Okay, so supportive care, that sounds, well, supportive, but what does that actually look like in the context of GBS?
Basically, it's all about managing the symptoms, preventing any complications, kind of holding down the fort while the immune system, chills out a bit and the body can focus on healing. This can involve things like close monitoring in the hospital, especially for patients who are having trouble breathing.
So for some people, that might even mean being on a ventilator for a while.
That's right. In severe cases, those muscles that control breathing, they can become weak, and a ventilator can step in and take over that workload until those nerves regain their strength. Supportive care can also include things like physical therapy to help maintain muscle strength and flexibility.
So you're preventing things from getting worse and then laying the groundwork for recovery. But I imagine immunotherapy is where you really go after the root of the problem, right?
You got it. The two big players in immunotherapy for GBS are intravenous immunoglobulin, or IVI. We love our acronyms in medicine. And then there's plasma exchange.
IV, plasma exchange, those ring a bell. Just to refresh our memory, how do those actually work?
Sure thing. IV Hig, that involves giving high doses of antibodies, but these are the good guys. They're collected from healthy donors. Think of it like sending in reinforcements to kind of calm down that overzealous immune system attack on the nerves.
So it's like flooding the system with those good antibodies to drown out the bad ones that are causing all the trouble.
You got it. That's a great way to put it. And then there's plasma exchange, which is kind of like it's a bit of a blood cleansing process. We remove the patient's blood, filter out those pesky antibodies that are attacking the nerves, and then we return the cleansed blood back to the body.
So both therapies essentially have the same goal, right? To put a stop to the immune system's attack on the nervous system.
You got it. And the good news is they're both quite effective, especially when we can start them early on in the course of the disease.
That's reassuring to hear. But what about those cases where someone doesn't respond to those initial treatments? Are there other avenues to explore?
Absolutely. While simply repeating IVI or plasma exchange, it's usually not the answer. There are other medications that we can consider, things that help to, modulate the immune system in different ways. And of course, researchers are always on the hunt for newer, even more targeted therapies. So there's a lot of exciting work happening on that front.
The field is always evolving.
Yeah.
So, when it comes to GBS, what are some of those big unanswered questions that researchers are still grappling with? What are the mysteries that remain unsolved?
One of the biggest head scratchers is that initial trigger. What is it that flips the switch in the immune system, causing it to go rogue and attack those nerves in the first place?
Right, it seems like we've identified the key players involved, like those gangliosides and antibodies. But that first domino, the one that sets the whole chain reaction in motion, that's still a bit of a mystery.
Exactly. Is it purely genetics? Is it environmental factors? Is it that initial infection that throws everything off balance? It's probably a combination of factors, a perfect storm, so to speak.
A true medical mystery novel, it seems. What else are scientists trying to figure out?
Well, we're definitely getting better at predicting which patients might need more intensive care and how long their recovery journey might be, but there's still room for improvement there. And then there's the question of long-term effects. Most people do recover well from GBS, but some folks are left with lingering fatigue, pain, weakness, even years down the road.
So it's not always a simple case of recovery and then back to life as usual. GBS can have a lasting impact.
Unfortunately, that's true for some people. We need to understand those long-term effects better and hopefully find ways to either prevent them altogether or at least treat them more effectively.
It sounds like there's still a lot to learn, both about what causes GBS and how to improve the long-term outlook for patients. But you're right, the progress that has been made, even just in recent decades, is pretty amazing.
Oh, absolutely. It's been remarkable. And with ongoing research and increased awareness, I'm optimistic that we'll continue to make strides in unraveling those mysteries, finding better ways to diagnose, treat, and who knows, maybe one day even prevent GBS altogether.
Well, that's a hopeful note to end on.
Yeah.
This has been quite the deep dive into the world of Guillain-Barré syndrome. We've covered a lot of ground, from those unusual triggers to the intricacies of the immune system and the latest in treatment options. Hopefully, you listening out there now have a much better understanding of this complex and fascinating condition.
It's been my pleasure joining you on this deep dive today. Always happy to talk about GBS.
And for our listeners, if you're eager to explore this topic even further, don't worry, we've got you covered. We'll be sure to include some great resources in the show notes. Until next time, keep those questions coming, and we'll catch you on our next deep dive.